Welcome to the Peds Hub podcast. We are a group of paediatric trainees in the Southwest who every month review a selection of articles that we find useful for our practice.
These are taken from the BMJ, Archives of Disease in Childhood Journals.
For the full articles, please go to their website, journals.bmj.com. Please note, these are our own opinions and are produced for educational purposes only. They are not intended to substitute professional medical advice, diagnosis, or treatment.
Thanks for listening.
Hi Simon, welcome to our podcast. Thank you for joining us today.
Hi Paulina.
So today I want to talk to you a little bit about febrile neutropenia, but to start with, can you introduce yourself, where you work and what your interests are?
Yeah, of course. I'm Simon Park. I'm a consultant paediatrician at the Royal Devon University Hospital. I've been working here as a consultant for 14 years, having previously been a consultant paediatrician in Stoke-on-Trent. I've always had an interest in paediatric oncology and have been, both the jobs I've done as a consultant have been in large paediatric oncology shared care units. In my training, worked in several of the big principal treatment centres, Ormond Street in Birmingham and in Oxford, and have been an active member of the Children's Cancer and Leukemia Group and was previously chair of the Shared Care Special Interest Group of the Children's Cancer and Leukemia Group, handing that over a couple of years ago.
And so when did the Exeter service develop? Because it's fairly unique, isn't it, in that we are not a major oncology centre, but we do give chemotherapy here.
So within the structure of children's cancer centres throughout the UK, there are the 20 principal treatment centres, which are traditionally associated with the old medical schools in major cities. However, in some regions of the UK, there has been delegation of extensive bits of cancer care for children to district general hospitals, which have been designated as paediatric oncology shared care units. The level of this delegation varies between different regions. In the southwest of England and the West Midlands, two regions where I've done most of my work, there's extensive delegation which allows the POSCUs to deliver most care, including infusional inpatient chemotherapy and intrathecal chemotherapy. Last time I looked in Exeter, we are the largest shared care unit in the UK, partly because we take the paediatric footprint of our own hospital, which covers East Devon, as well as North Devon and South Devon. We provide inpatient infusional chemotherapy, we provide intrathecal chemotherapy services, as well as a broad portfolio of support services.
And I should, by the way, mention that we are recording in the hospital, so apologies for the bangs that you'll hear in the background. The fact that you're a centre that provides quite a lot of things makes a huge difference to the patient's cancer treatment and their pathway, doesn't it, in terms of minimising time away from home and that sort of thing. And that brings us quite nicely onto this paper. So the title of the paper is "Can I Go Home Now? The Safety and Efficacy of a New UK Paediatric Febrile Neutropenia Protocol for risk-stratified early discharge on oral antibiotics." And it was written by Dr. Jackson et al. And published in the March 2023 edition of Archives of Disease in Childhood. So, I found this paper really interesting. I don't know if you'd heard about this study before, but it sounds like a really important study, again, for just helping reduce the burden on patients and their families.
So we were approached to be involved in this study. As it happened, we didn't get involved in contributing patients due to various logistic reasons. I've previously been part of the supportive care group within the Children's Cancer and Leukemia Group, and been involved in quite a lot of the discussions and meetings and previous plans to introduce a risk-stratified febrile neutropenia strategy across the UK. And this paper takes that work to the next level, produce that evidence I think is necessary to reassure clinicians.
We'll come on to that, but even within this framework, it seemed like it was quite difficult for some clinicians to get on board, and we'll talk about the barriers a little bit later. So this is building on the Australian data set, wasn't it? They originally developed the Australian, UK, Swiss, it's in the title. They all developed it together. The AUS rule and the home care criteria. So the first studies were in Melbourne, is that right?
Yeah, I think so. So the Australians, of course, have had a long history of developing risk stratified care, which reflects the geography of Australia. People in the southwest of England get upset about travelling 100 miles up to Bristol, but I don't think they have any concept of what that means if you live in rural Australia and you're having to travel several hundred miles for your nearest unit. So I think there was a clear drive towards seeing if it was possible to have a less inpatient intensive approach to the management of febrile neutropenia in Australia.
It's a great initiative and definitely has its benefits for our patients as well.
Inpatient stays, if you ask families what they find stressful, what they find difficult and challenging, it is those times in hospital, particularly those unplanned admissions. If you think about children coming in for routine chemotherapy, actually that is something that families can plan for. But actually those 4 o'clock in the morning, rushed into hospital, the temperature, unplanned admissions are hugely stressful. The impact is on the family member that takes the child to hospital, in that they may not have accommodation, they may not have their toothbrush with them, all those immediate care issues, notwithstanding the fact they've got an unwell child with them. But then who's looking after the siblings? Many families are single parent families. Impact on the work and employment of the parents, on their income, and the impact on the child's education and their socialization, which is immense and shouldn't be underestimated.
Yeah, absolutely. So let's start talking a little bit about our current febrile neutropenia pathway, which I'm sure most listeners are familiar with, but at the moment, it's fairly standard treatment that a child with suspected febrile neutropenia will present to the hospital, and the gold standard is they should have bloods, cultures, and start their IV antibiotics within the first hour of presentation. And then in most units, they'll have 48 hours worth of IV antibiotics until those cultures return as negative, or continuation if they are clinically unwell and or the cultures are positive. Any differences as far as you're aware in other departments?
No, so the introduction of NICE guidance has produced significant harmonisation in people's approach and definitions. However, there still remains this historical dependence on the 48-hour rule of cultures for all children before they can go home. We recognise as clinicians that many children who come in with neutropenic fever are very well, that most of those children do not have a bacteremia, and there may be a trivial explanation for their fever, but unfortunately that mandates them still staying in hospital 48 hours.
And so if we start looking at the AUS rule, so the stratification they suggested was you had a score of 0 to 3 according to whether or not you met the criteria. So the first was they'd had preceding chemotherapy, more intensive than ALL maintenance, which would score 1, a total white cell count of less than 0.3 times 10 to the 9 per litre, and or platelets less than 50 times 10 to the 9 per litre. So each of those would score 1. So they talked about the minimum observation period, if clinically stable, as well as fulfilling home care criteria. And for an AUS score of 0, they could be observed for 4 to 8 hours if there are no other concerns. With a score of 1, 4 to 24 hours, a score of 2, 24 hours, and a score of 3, 48 hours.
So I think the first criterion mentioned about chemotherapy more intensive than ALL maintenance, it seems like a slightly odd criterion to put in there. But actually, when you think about the duration of ALL maintenance, probably at any one time, almost half the patients that are on chemotherapy will be on ALL maintenance, particularly within a shared care unit. So that is a large number of patients who have a great potential to come into hospital with intercurrent infections.
And then if we talk about the eligibility criteria for home care, it's quite a long list. I'm just going to read them out because they are all quite relevant. So they had to have a disease status that was leukemia or lymphoma in remission, as per the last bone marrow aspirate, or a solid tumour that was stable and responding. And they had to be a low-risk disease group, so not any of ALL induction or acute infant leukemias, acute myeloid leukemias, post-allogenic hematopoietic stem cell transplant within 3 months or still on immunosuppression, congenital immunodeficiency, aplastic anemia, or trisomy 21. And they had allowed within that criteria that any centre could, if they had any local concerns, they could add in any other specific diagnoses. They also needed to have no confirmed focus of infection requiring inpatient care, no medical complication requiring inpatient care, no severe sepsis at presentation, the availability of a 24-hour caregiver, good education of the patient and carer on reportable symptoms, availability of a telephone, and they needed to be living within 1 hour of the treating hospital, and also no previous history of non-compliance with medical care. And then they added an extra criteria, so treating team preference. Any thoughts on this list?
No, I think it's a really good list. Actually, it's interesting for our patient population that we do have some children that are greater than an hour away from the hospital. So for those, we do operate a lower threshold for admission and for keeping in hospital. Many patients will come with febrile neutropenia with other comorbidities at the time, for example, pain, nutritional problems. And it's really important not to get overly focused on the sepsis side of things, but to ensure that you treat the patient holistically. So I think it's a really good list.
Yeah.
It was always an obligation to put in the treating team preference so that you could have a get out of jail free card if you chickened out sending the children home.
Yeah, and I think just to get more centres on board with this. So if they were eligible for home care, then it was important that the parent or the guardians received education about the home care programme prior to discharge, and they were recommended to go home on oral antibiotics of ciprofloxacin and coamoxiclav or clarithromycin if they were pen allergic. And importantly, they must have tolerated 1 dose before being discharged. And they also needed the parents to be willing to do 4 to 6 hourly temperature monitoring when awake. They didn't specify what to do when asleep. And the clinicians would have conducted a daily clinical telephone review until the cessation of antibiotics. And then criteria for cessation was similar to our standard febrile neutropenia pathway. So they needed to be clinically well, apyrexial for more than 24 hours, have a negative blood culture, and have no requirement for continuation, for example, a UTI or a chest infection. Do you think we've got enough staff to be able to educate?
Absolutely. And I think families are generally often the most reliable observation takers. And, we certainly delegating that to families is entirely appropriate. And doing a daily call is something that we would do as part of standard care after discharge, actually. So I think this is all very, very attainable. And if you compare it to what we're doing at the moment, which is an inpatient stay, a telephone call follow-up is relatively resource de-intensified.
And I think, later on it talks about this in the paper, but the parents, as long as they were involved in the discussions, they were very open to this risk stratification. They felt reassured by understanding their child's disease a little bit more, having those discussions with the clinicians, and certainly they're very, what we call professional parents, aren't they?
Yeah, so absolutely. These are families who've been through really, really horrible times and horrible conversations and are used to the evaluations of risk that are necessary in managing children with these complicated conditions.
So looking at the reasons then for review, because obviously the parents could represent or after the clinician's daily review, they could request the patient to come back into hospital. So the first reason was for an ongoing fever greater than 72 hours or a new fever after being afebrile for 24 hours. The next one was feeling unwell or developing new symptoms and signs, any parental concern, a significant decrease in oral intake or significant increase in output, positive blood cultures or a new infection identified after transfer home, severe or persistent pain, chills, rigors or shaking, or not afebrile by day 5 of home-based care. So fairly common sense reasons for review. And then reason for readmission after that review was a fever greater than 38 degrees beyond 5 days from the start of the febrile neutropenic episode, clinically unwell or unstable, or an infection requiring inpatient care. So let's move on to the methods. So it was a prospective service evaluation, and they used 13 specialist centres between April 2020 and April 2021. They had to submit data at discharge or at 7 days of presentation, whichever was soonest, and again on representation. They did a monthly evaluation of data, and they had stopping criteria that they identified prior to the implementation of the protocol. So there was red criteria, which was immediate discontinuation and reverting to an original policy, and that was an avoidable death or an ICU admission from bacterial sepsis in a 0 or 1 school group discharged before 36 hours. And then amber criteria would have resulted in a modification of minimum admission durations. So that would have been a higher number of readmissions than those that they expected, and they calculated an expected readmission number at 15%, based on previous papers, including those who had undergone standard neutropenic treatment, or a high number of representations within the first 24 hours after presentation, and that criteria is more than 50%. So let's talk through the results a bit. Any immediate thoughts when you looked at the...
So I think, the striking thing is that they really good numbers of patients. So they had, 729 episodes, over 405 patients. Most of these from principal treatment centres, but I think that probably just reflects the weight of numbers that sit in most of the principal treatment centres. The 79 episodes in 7 days, initial episode, and 64 were representations. The striking and most important thing is that they found that there wasn't a significant risk with employing these rules, that they did not have any major adverse outcomes using a risk stratified criteria to allow earlier discharge of children. And that is the thing that I think we all needed to feel reassured about.
Yeah, because they'd carried this out in Australia already, hadn't they?
Yes, so there was background data that suggested that this was going to be safe. Only 20% of the patients presented were eligible for the home care criteria. Some of those were kept out of the home care criteria because of the treating physician decision. But that's still going to be a significant number. If you look at it, was 145 episodes of febrile neutropenia were deemed suitable for home care with oral antibiotics.
Yeah, I think there was 5% of those that would have been eligible for home care were not eligible just due to unspecified clinician's choice.
Yeah, I think that there is always a little caveat about that, in that these were units that welcomed this as a piece of research. And so there may be a little bit of unit bias towards clinicians that were more likely to accept a risk stratification.
That's a really good point. Yeah.
As opposed to some units which have very traditional and risk-averse criteria.
And so most of the reasons for non-eligibility were...
The commonest reason for non-eligibility, I think, was the patients who didn't fall into a low-risk disease group. And I think that within the inclusion criteria, there are patients who had AML or infant leukemia who are obviously going to be excluded. So I think that was the single biggest, and I think 36% of patients were excluded because of that.
So if we look at the core outcomes according to the risk group, so AUS score 0 through to 3, it was really encouraging to see that there were no deaths from infection or any other cause or any ICU admissions in the low risk, so 0 or 1 score. Always reassuring to see.
Yep.
Then there were slightly more positive blood cultures in this paper than there had been, I think, in the Melbourne studies. And it's just worth mentioning, which they talk about in the conclusions, that the diagnosis of a positive blood culture, I think cons were treated slightly differently in the Australian group versus this paper, in that they did count a cons as a positive blood culture. And they just, that obviously can be a positive blood culture, can't it? Because they've got lots of plastic inside often. But I think that the feeling was that it wasn't always the clinician that was looking after the child that was reporting the information. So it was difficult for them to make the assessment as to whether or not it was a contaminant and you had a well child, or if it was a significant blood culture. So they threw all of them in. So we have got a decent number of positive blood cultures.
Yeah, I think looking at that number would be higher than what would be in even previous published UK data. So I think we typically reckon about 10% positive blood cultures, whereas even in the low risk group, the incidence was 19%.
And then in terms of significant infections requiring IV antibiotics, for the most part, that was increasing across the risk stratification. 0 and 1 are fairly similar, but then you've got higher percentage of patients in the group 2 and 3, as we'd expect.
Yep, absolutely.
So looking at the discharge time, it looks like 50% of the low risk and home care eligible patients were discharged by day 1 versus about 18% in the higher risk but home care eligible patients. And by 48 hours, 75% had been discharged in the low risk group.
I think the thing to note here is that amongst low risk patients, that half of them were discharged after 1 day in hospital. which is a significant reduction in what would be expected from previous protocols.
Yeah. And actually, as we get more comfortable with this protocol, we'd hopefully be seeing that number of hours reduce even further if we were to employ it fully, and reduce it down to that 4 to 8 hours. I think that might take a little bit of time, but
that is going to require significant cultural shift, I think.
yeah. And then if we look at the representation, so the paper does talk about they were expecting about 15% representation, and they saw in the AUS 0 group 7% representation within 7 days, and all of those were readmitted. In the group 1, it was 11%, and 10% of those were readmitted. And then AUS 2, 5% represented within 5 days, and 5% were readmitted. And then in group 3, 9% representation, and then 9% readmission. And in your experience, how many do you see readmitted roughly? Because I don't see tons of readmissions in our febrile neutropenic patients.
I think we accept that there's always going to be a readmission rate. If you think about the non-bacteremic causes of febrile illness in children, many of these be viruses. In our general non-oncology practice, we would frequently see children who are still febrile after 3 or 4 days. Yeah. That wouldn't generate admission.
Or febrile again with the next bug that they picked up in their
and high prevalence of viruses in the community will generate recurrent attendances. So I don't think that is surprising, and I don't think it is worrying. And I think an expectation is that there will always be some reattendances and representation. And I think that's a testament to good education of families and a really safe system, actually, rather than a cause of concern.
Yeah. And again, the data was reassuring in that none of the readmissions needed an ITU admission in either the home care eligible or the home care ineligible group, nor were there any deaths from infection or from any other causes. So again, really reassuring for this protocol. They talked through the organisms isolated in blood cultures, and that's just where it was worth noting that the greatest number of organisms was seen in the cons group, so 25% of those, and otherwise it's a smattering of the usual bugs that we would see. So to reiterate the main outcomes, they found that 20% were eligible for home care, none of those were admitted to ICU or died in the subsequent 7 days, 41.4% were considered low risk, and there were higher rates of positive blood cultures in the higher AUS risk group, as we would have expected. The rate of readmission was 16%, which was similar to their previous trial data, and as I said, also similar to standard UK care in 2017. And we touched on this, that there were really positive parental views from those involved because they were able to be involved in the decision making and they understood the risk and why they were stratified into which category.
So I think the piece of work that you feel does come after this is looking at whole patient journeys. So looking at what the impact is on patients who are allowed this slightly softer touch approach to neutropenic fever and what the impact is on that. And you could look at a whole bunch of stuff downstream of this in terms of missed education, in terms of missed work, in terms of quality of life measurements for families who have this as part of a sort of structured plan throughout their whole treatment journey. There is a limitation in this study, which is that this was observational, not randomized. Yeah. So we don't have a control group of patients who weren't allocated a risk score. There is plenty of historical data to support that. I don't think it makes the study in any way less valid. But I guess, for intellectual purity, it would be nice to have seen comparable data from a control group without risk stratification.
I doubt we're going to get that now, though.
I think that horse is bolted.
Yeah. And then just thinking about the barriers to treatment, can you think of any way that, is it just time and exposure?
So I think time is going to be incredibly helpful. You're dealing with a group of clinicians in pediatric oncologists who are instinctively risk averse around infection. We all have experiences of children dying or becoming terribly unwell from sepsis. And I think those experiences necessarily colour our ability to de-escalate treatment. It's always easier to add something in based on research than to take something away. And I think that it will take a bit of a cultural shift to accept that the evidence is that many of our patients are safe to manage in a more conservative way without the need for prolonged periods of hospitalisation. But I think it's probably going to take quite a long time for that to become embedded in clinical practice.
And the filter down through to the smaller district generals will, I suspect, take even longer.
Yes, I think it will be interesting to see how that happens. One of the limitations in paediatric oncology shared care units is, of course, that there isn't a 24/7 oncology experienced clinician available. And in the absence of that, the default setting will always be to treat, to be safe, to be careful. And I think it's hard enough to convince an oncologist with the evidence in front of them of the need to de-escalate care, or the advantages of de-escalating care. Doing that with someone who is an acute paediatrician covering an acute ward with an unwell patient in front of them, I think it'd be even harder to convince them.
And has there been any discussion in the Exeter team as to whether or not we take this into account?
So I think there has been general move towards more risk stratification of our patients. We've not yet moved towards adopting the AUS model in terms of risk stratification, but I think in practice, the decisions around de-escalation of care are taken by myself and my colleague, and we are using similar or equivalent risk stratifications. And what would be really helpful would be to start to incorporate this into protocols and do it on a network-wide basis, so that there is reproducibility between the different centres that provide outreach care to children across the region.
Yeah, because I think there's nothing more frustrating to parents to be treated in one manner in one hospital and a completely different manner in another hospital.
Absolutely.
And then we mentioned some of the limitations throughout our chat, but we talked about a little bit of bias. So you've got that bias of the units that are signing up to it are likely to be slightly less risk averse than others. And they did only record intention to treat. So they didn't actually specify if they were eligible for they only specified that a patient was eligible for home care, not if they were treated at home. But then they did provide us with the duration of admission.
Absolutely, I think that is an equivalent measure.
And then the total duration of the episodes, they capped that at 7 days in order to encourage that rapid turnaround, mainly for the safety data. So we don't have a full duration, but actually we're more interested in the shorter durations rather than the longer durations.
The longer durations are likely, and I think the evidence we got from this study would show that it includes the more high-risk patients who are going to be not eligible for home care anyway. Exactly. So I don't think it matters particularly.
Brilliant. So thank you so much for talking through the paper. And we like to end on a lighter note and ask if you have any favourite books or any favourite films and why you've enjoyed it.
Okay, so my favourite film would be, without doubt, The Princess Bride, which is the most endlessly quotable festival of joy that anybody could ever watch. Highly recommended.
Definitely agrees with that.
And my favourite book is rather more serious. It would be Love in the Time of Cholera by Gabriel Garcia Marquez.
Okay, and why did you like that one particularly?
Because I'm a soppy romantic old fool.
I would not have guessed that. That's awesome. Thank you so much, Simon. Thank you.
That's all for this episode. As always, if you have any questions or comments, please feel free to get in touch via our email address podcast@pedshub.co.uk or via the PedsHub website. Equally, if you'd like to get involved, we always welcome your voices, so please do get in touch. Thanks for listening.